Medicine 3. So history-wise, he is a Mr. S, 70-year-old male, daily wager from Tirupattur, presented to emergency department with the complaints of fever for 5 days, headache for 3 days, vomiting for 3 days, and altered sensorium for 2 days. So the fever was a high-grade fever with chills and rigors with the evening rise in temperature. It's an intermittent fever, subsided with the paracetamol. He used to take medication from the local clinic. He also had a complaints of headache, which was diffuse and holocranial type of headache. There was no blurring of vision associated with that headache. He had a complaints of vomiting, around 3 to 5 episodes of non-projectile, non-bilious vomiting every day for 3 days. And the vomiting contains the digested food particles. It was non-bilious, non-projectile. And in the 1 day prior to admission, he started behaving abnormally. The family noticed he had a decrease in verbal output and talking irrelevantly, and sometimes scolding in bad words also. So which there's an altered sensorium was sudden in onset. And the negative history is there was no history of any weakness or hemiparesis or any abnormal movements, no history of ear pain, ear discharge, no previous history of facial trauma, nasal discharge, no history of loose stools, abdominal pain, no history of cough, breathlessness, or no history of constipation or any altered bowel complaints. So past medical history wise, he was diagnosed recently with hypertension for past 1 year, was taking amlodipine, very poor complaints for the medication, and diabetes mellitus was diagnosed 6 months ago during the incidentally they diagnosed when he went for other blood checkup. No previous similar admissions, no history of any surgical interventions. Personal medical history, he used to smoke 2 to 3 sticks per day for past 40 years and used to take alcohol 370 ml per day nearly for past 40 years. This was 2 to 3 times a week he used to take. He used to take a mixed diet. He used to have a vegetarian and non-vegetarian in an equal amount. With these complaints, he went to outside hospital. The outside hospital treated him like bacterial infection, treated him with antibiotics for 2 days. Nearly 4 doses of antibiotics he received before he came to our emergency department. On emergency department, he was conscious, cooperative, but he was a bit drowsy, but obeying commands. He used to put out his tongue out on nasogastric tube. When he came to emergency ward, he was on NG tube, and his vitals wise, heart rate of 86, BP of 130/80 with a respiratory rate of 22, saturating 99% on room air, not requiring any oxygen support. He was febrile, 101 Fahrenheit, with a muddy sclera, great thick clubbing he is having, and poor dental hygiene with bilateral temporal and supraclavicular hollowing, no pallor, cyanosis, edema, or lymph nodes. Respiratory wise, on inspection, he had an emphysematous chest with reduced cricosternal distance, and a trachea was in the midline with hyperresonance and increased AP diameter. Crepitation over left infra-axillary region with interscapular area also. CVS examination was insignificant, and abdominal examination was soft. It was non-tender, no organomegaly, no signs of free fluids. CNS examination, he was not oriented to time, place, and person. He was drowsy, but he was obeying commands. Speech was normal, and cranial nerve examination, there was no facial deviation. Gag was present bilaterally, even though NG was there, but gag was present. No tongue deviation. Fundus was checked. There was no papilledema. Moving all 4 limbs. Reflexes were 3+ in all over the joints. Plantars were flexes. No cerebral signs. Neck stiffness was there by both direction. Normal gait. He was able to walk actually with the help of supports, and no spine tenderness on examination. So summary, 70-year-old male with a history of fever with a headache and altered sensorium, acute onset. Acute onset with we did a laboratories in the later, and we went through the history back and asked. He had a history of half-cooked pork intake. That was 1 week ago. He and his friends went outside and had it in a wild field. So the initial differentials we considered were on the time of admissions was pyogenic meningitis, viral meningoencephalitis, aseptic meningitis, tuberculous meningitis is very rarely, brain abscess with mass effect, and intracerebral malignancies, glioma and all very rarely. So in initial investigations was done that shows the CBC. CBC shows the WBC of total of 20,300 with a neutrophilic count of 90%. And we did a CSF. CT was done that ruled out the features of raised ICP. CSF was done that shows glucose of 34 with a protein of 234. But CSF culture shows many pustules, no bacteria. It unable to isolate any special organism. But CSF count shows WBC of 38 with neutrophils of 49. and lymphocytes of 36%. Blood cultures were sent in vivo for fever for 5 days. That grown Streptococcus suis, which came later to sensitivity to the vancomycin and ceftriaxone. So this Streptococcus suis is a little bit rare organism in our settings and in India also, but common organism in Asia, in Northeast Asian countries like China, Taiwan, and other northern countries. So LFT was normal, and other metabolic parameters were normal, and MRI brain was done. It shows a diffuse supratentorial volume loss with features of probable ventriculitis. This was discussed with the senior neuroradiologist, but without any features of hydrocephalus or obstruction. And I just want to talk about the Streptococcus suis. It's a little bit rare condition, but not very, not having high mortality rate in populations as of the studies released all over the world. It's a facultative gram-positive anaerobic alpha hemolytic cocci, most of zoonotic pathogen that causes serious systemic infections from ear infection to the septicemia also, and mostly related with occupation related with related with the pork and the ingestion of pork. The most common clinical manifestations of meningitis and sepsis all over the world. So most of the studies are done in the China and the Taiwan that shows us the prevalence of meningitis and the septicemia in most of the patients. And these are the countries in India they mentioned here, but there are in CMC also. We are not having enough data to tell Streptococcus suis as a very bad infection. And I discussed with the senior microbiologist. The sir also mentioned meningitis is a rare presentation of Streptococcus suis in an Indian population. And this is the picture that shows the Streptococcus suis will stay in most of the parts in the nostrils. It will cause multiple issues in a pig also. The same issues can happen in the human also, whoever is consuming that one. It can develop ear infection, it can develop meningitis, it can develop arthritis, bone infection, and it can develop bad septicemia with skin infections also. So human infections due to consumption of pork products suggested that gastrointestinal tract is the most major route of entry in cases of Streptococcus suis, especially in a patient with a damaged intestinal barrier. So SS2 is a swine pathogen. It's a common that will cause the human bacterial meningitis. Mortality is very low, 2.4%, but the hearing loss is very high. This depends upon the studies which was done on the Taiwan and China. Septicemia is one of the most common mortality cause of Streptococcus suis. So these are some of the complications. It can cause like a toxic shock syndrome like pictures. It will cause severe skin infections also, Streptococcus suis. Other than that, CNS meningitis and septicemia. So treatment-wise, mostly most of the Streptococcus are sensitive to the beta-lactams. In our patient also, the bug was sensitive to ceftriaxone. Initially started with empirical management and tapered to the ceftriaxone when after the sensitivity arrives. So in view of suspected probable ventriculitis with the benefit of patient care, so we plan to give the antibiotics for 6 weeks. He is currently on ceftriaxone. We are planning to continue for 6 weeks. In between, we are calling him for the OPD to check whether he is developing any other complications like joint infection or any ear infections. So learning points from this short cases like meningitis, Streptococcus suis is one of the rare case, but the thing is it will present like other bacterial meningitis. Treatment is simple, ceftriaxone, but the complication is very rare when we not identify the organism as soon as possible. Thank you.
Thank you, Dr. Brightus. Can I ask the audience for their thoughts and comments on this case?
Is the patient, the probability of developing hearing deficit is 60%. Did your patient develop hearing deficit?
No, ma'am. As of now, we are asking him to check it in the ENT also, ENT OPD. We are asking him to following up. But when he was present in the ward, he does not have any problem with the hearing. He was able to receive an.
Did he receive steroids before he gave?
No, ma'am. He didn't receive steroids.
One point is, if you have pyogenic meningitis with hearing deficit, a prolonged course of dexamethasone may help in decreasing the hearing deficit. And so that is one thing. Why was he not given dexamethasone?
In this case, we are thinking of the bacterial meningitis and more than that of the hearing.
Anybody else? Dr. Brightus, thank you very much. I have few questions to ask you. The first is, you said he ate half-cooked pork a week before. Is that the incubation period between eating and the development of clinical manifestations according to literature for S. suis?
It's eating the pork in between with his friends.
Yeah, so because that's the incubation period, I just wonder if it matched with what was expected. Are there previous reports from India on this?
Some of the studies I searched, sir, from India, I not able to find anything. I asked our microbiology. Streptococcus suis in the bacteria, as a bacteremia, they used to see some of the cases, that also very rare. But with the presentation of meningitis, this is the 1 or 2 cases, and they are trying to get.
Now, the other thing is, did the risk factors contribute? Because from what you described, I suspect he has COPD.
Yes.
And was his diabetes controlled or uncontrolled?
His HbA1c was 5.7 only, sir. It was recently diagnosed.
Okay. Were there any other clinical manifestations apart from meningitis?
No, sir. He did not have in between. During the ward admission, he required 2 liters of oxygen with the left-sided crepitations, but that was in the subsequent X-rays, and it was cleared within 1 or 2 days.
Okay, so you would get lung